Good morning, everyone. I'm Dr. Melissa Gilliam. I'm a professor and researcher in obstetrics and gynecology at the University of Chicago, where I run the family planning services and I practice as a pediatric and adolescent gynecologist. And so it gives me tremendous pleasure to welcome you this morning. I am a member of the section of family planning where I work with people like Lee Hasselbacher, who is our policy coordinator, who's just done a wonderful job of bringing us all here this morning. But also in the section of family planning, we conduct research and we provide care for patients. And so I want to start with patients because today we're going to talk about policy and clinical care and some of the logistics. And this is a working meeting and a meeting in which we'll get into the nitty-gritty. But I want to frame Seth by talking about patients. Actually, today is one of my favorite days because it's Wednesday. And on Wednesday afternoon, I spend my time talking with parents and children about their health and their well-being and their going to college, and contraception is always a very important part of that conversation. It's a tricky conversation because at the University of Chicago we take care of patients with many medical illnesses, and so we often have to go through a complex matrix thinking about what contraceptive method is best for which patient, and also which contraceptive method does she want. And we use these for a variety of purposes, whether it's for a medical problem, whether it's for painful periods or massive bleeding, but also in a variety of types of patients. So some are struggling with their weight or other issues. And so clearly not every contraceptive method is, you can't just interchange them. So I often struggle with an ethical problem. Because what we learn in medical school is that we give high quality care, and that is helping women get what they desire. But then on the back end, you're often saying, will their insurance actually cover it? And so do I counsel them about what's best for them and what they want, or do I say, I'm going to only talk to them about a few things? And so that's been the dilemma. Now is the time to talk about this issue because we now have amazing legislation in the Affordable Care Act that really understands that contraception is a central part of women's preventive health care. Just fundamental. Right? Women, when they come to see us, they're not focused on the contraceptive method. They're thinking about their lives. They're thinking about going to school and taking care of their family. Contraception is like transportation, right? You just need something that helps you get about your work. And so what we see in the Affordable Care Act is that people finally get this. Let's not make it so complicated. Let's focus on making sure it's high quality. In fact, the CDC just produced a monograph looking at what ensures high quality care. And one of the things they say is it's access to all federally approved, all FDA approved methods. So that when you get into a clinical setting and suddenly you're forced to try to figure out what women can actually get, it's really a problem. So about maybe even under a year ago, I just started to say, enough. And I turned to Lee Hasselbacher, our policy coordinator, and I just said, enough. This is really complicated. Even in our own institution, we are not able to give women all methods. And I had copied something I saw in New York where someone had created a task force. They said it was an IUD task force. And I was like, oh, we need a task force here. And I practice in the spirit of reproductive justice, so I don't think the task force is around a single method of contraception. A task force is around equity. Equity for all women so that they can decide when and whether they want to bear children. And so our task force was an opportunity to bring allies and people who really care about equitable care for all women, regardless of who they are, their color, their race, their beliefs, equitable care. But instead of finding a big battle in front of us, we actually found incredible allies, and one of the most important allies has actually been in Director Hamos' office. Director Hamos herself and Kai Tao, who said, we're here to partner with you. You believe the same things that we believe. And so this morning is an opportunity for all of us who really believe in the value and the importance of contraception as an integral part of women and their family and their partners' health and well-being, to get together to start to talk about how we are going to ensure equitable access for all women. One of the beauties of the work that we do is that we get tremendous support from people. And so one of our great supporters has been the Irving Foundation, who allowed us to serve this role as a convener. And so what you'll see is we'll actually step back and let you all do the work today. And our goal is really to help facilitate it. When we first started working with the Harris Foundation, they talked to us about the importance of partnering. And so we were able to reach out and have a very, very important partner in EverThrive. And so I just want to thank EverThrive so much for co-sponsoring this event and for all of their supporters who've made this possible. We also were able to receive support from a woman who lives in Hyde Park who just cares deeply about women, and particularly women on the south side of Chicago. And her name is Emlyn Eisenach. And so she said, go to the Gleacher Center. I want to make this possible. I want this central where people can access it. So again, I also want to thank Emlyn for making this possible. And then I also want to thank all of you for being here. This takes time away from your work and your other commitments, and so I really very much appreciate your presence. I'm going to next introduce Julie Hamos, and this is just such a wonderful opportunity because it allows us to, I think, we can serve as a model for the rest of the country, and really quite literally, we've been working with some national organizations, and they're really struggling to understand how best to provide contraceptive care for women. And so this ability to partner and already be directly in contact with such an important initiative at the state level is really important. So Julie Hamos was appointed Director of the Illinois Department of Health Care and Family Services in April 2010. And the department is the largest state agency with management responsibility for the Medicaid program and child support services. It has a $17.7 billion budget and a staff of 2,400. So what an amazing, amazing job she has before her. Before joining HFS, Julie served as state representative for the 18th District for more than 11 years. While in the General Assembly, she was chief sponsor for key health initiatives such as the Illinois Health Information Exchange and Technology Act, the Consumer's Guide to Healthcare, the Children's Mental Health Act, Universal Hearing Screening for all newborns, and the Older Adult Services Act. Long before seeking public office, she championed public interest policies and community issues as an attorney, legislative counsel, community relations consultant, and advocate for more than 20 years, and served on the board of Planned Parenthood Chicago. So no wonder we have such a great champion for this issue. Again, thank you very much for being here, and we look forward to this day.
Good morning. Thank you, Melissa, for that nice introduction, and welcome to all of you. I'm so glad to be here. It's a pleasure to look out and know that we're all working together to provide contraceptive equity and to look at all the challenges that we need to overcome to make sure that happens. I want to introduce on our team Linda Wheel, who is the manager of our Women and Child Health Bureau, kind of a bureau. Yes, Linda? With her, Gwen Smith, and I guess newly working with us is Allison Rhodes. Welcome, Allison, to our team. And also want to introduce Tia Sani, who is our Director of Research and Data Analytics, who's just basically a feminist and cares about these issues. And then Kai Tao, who is a relatively new member of our team, working with me in the Director's office, and you'll be hearing also from her, came to us from Planned Parenthood. I served on the board of Planned Parenthood a number of years ago before they kicked me off when I became an elected official, and have always been a very big supporter, and these are the reproductive health issues are issues that I championed as a legislator. So I'm glad to be doing it now through our work at HFS. Now, do I know how I'm doing this? No. Okay, here we go. So let's start with some of the basics. Medicaid and pregnancy. So you may know that the total Medicaid enrollment is over 3 million people as of it's actually a lot more dollars, but 3 million people as of July 1st. About 1 million, really 900,000 to 1 million, are girls and women on Medicaid who are childbearing age. So it's a very big proportion, girls and women, and we consider that the 13 to 49-year-old group. Illinois Medicaid pays 94% of teen pregnancies, and you probably also know that Illinois Medicaid pays for 54% of all deliveries. So I want to, again, I mean, this is such a big number, and we have so many constituents, if you will, members of Medicaid who we have to pay attention to. And so really, it did challenge us with the direction and leadership of Linda and Kai to look at what policies we have in Illinois Medicaid that need to be improved. And that's what we've been doing. Oops. So I'm glad to announce that today. I also want to give you some backdrop here on Governor Quinn. And he did have a decision on Hobby Lobby, which is, again, the backdrop for everything we're doing in Illinois Medicaid. He is our governor. He says healthcare is a human right. The Affordable Care Act is meant to give all Americans access to decent, affordable health care. That means full access to health care for every woman in America, regardless of who they are or where they work. A woman's personal health decisions should stay strictly between her and her doctor. Unfortunately, the U.S. Supreme Court's decision takes these choices from a woman and gives them to her employer. We will continue to fight to preserve the right of Illinois women to make their own health care decisions based on their own beliefs, not the beliefs of the person signing their paycheck. And I think everybody in this room would agree with that. In Illinois Medicaid, with 1 million women of childbearing age, we have an opportunity and, in fact, a commitment to make sure that we are not following this decision, but that we are providing contraceptive equity and, of course, making sure that all methods are available to all of our clients. So today we are announcing the Illinois Family Planning Action Plan. Our goal is to increase access to family planning services for women and men in the Medicaid program by providing comprehensive and continuous coverage to ensure that every pregnancy is a planned pregnancy. And you will be able to find these on our new webpage when you leave here. On our home page has a new tab on Illinois Family Planning, and you'll be able to find the draft of this family action plan, and we will ask you to make comments on it and to give us feedback. So the family action plan has 2 actions. First of all, that payments and operational policies should reflect the value HFS places on providing the most effective form of contraception. And the second action is that health plans and providers in the Medicaid program should make all family planning options available to Medicaid clients in a convenient and seamless manner. So the Medicaid family planning policy has been in place for a long time. We restated it in a provider notice that we sent out on June 26th. And I want to make sure that you know that that is out there with our providers, and we will ask you to help us enforce it. Because we send a lot of provider notices, and it's always very important that the constituencies know what we're expecting from our provider community. First of all, we tell them in this provider notice, again, this will be on our website for you to review, that all Medicaid providers must provide the full spectrum of family planning options with no cost sharing. The free choice of provider statute allows clients to see any Medicaid provider of their choice with no managed care restrictions. Clients should receive education and counseling on all FDA-approved birth control methods, from the most effective to the least effective, with the most effective presented first. And we believe that is LARCs, such as intrauterine devices and implantable rods. We don't just believe that, that's what the research shows. And that's what I think is now the expectation and the standard of care for family planning. Contraceptive methods must also include over-the-counter and prescription emergency contraception. LARCs and emergency contraception were the most directly threatened by the Hobby Lobby decision, although I'm sure we're going to hear from Lori and others that all forms of birth control are threatened by that decision. And many other things, I think, slippery slope. So this is our basic policy that we expect from our providers, and it's very important for us, everybody, to help monitor and make sure this happens. So the research shows that LARCs are safe and effective for women and girls of all ages. And I wanted to just share this one slide about something we learned about recently, and I think you might have too. It got a bit of a press attention, that the Colorado Department of Public Health and Environment had an initiative to help low-income women get LARCs. And they had impressive results. The teen birth rates dropped 40% from 2009 to 2013. The teen abortion rates dropped 35% from 2009 to 2012. The infant caseload for Colorado WIC fell 23% from 2008 to 2013. And the total Colorado state savings in 2010 alone were $42.5 million. So this is good policy and good financial policy as well. So our action one is to make some changes in our rates and operational policies. Again, we really searched internally, what can we do better? So the first thing I want to announce is that we plan to double the provider reimbursement rates for LARCs and vasectomies. We already have increased, but as part of this whole action plan, the 340B providers dispensing fee, and we changed that. We're going to allow medical provider reimbursement for 2 services on the same day when the visit includes a LARC procedure and another kind of exam. We think this is really important. The same day concept, we're tired of women having to be sent away to come back another day. You know that's not working. I see a lot of people and this is a really key component of our new LARC policy. We're going to allow FQHCs to bill fee-for-service for permanent non-surgical sterilization kits with Assure, and we're investigating how we can allow hospitals to bill LARC insertion immediately postpartum after delivery. Action 2, we need providers to make family planning accessible. We're going to require all providers to submit their family planning policies annually to HFS, including the referral policies for those which invoke the right of conscience objections. We're going to continue working with the LARC companies. We've started down this path to ensure that there's adequate inventory for same-day insertion. We want you to have these LARCs on your shelves. And they've made a commitment to us already that there will be an ongoing training program to really help our provider community understand the effectiveness of LARCs. And we're going to communicate to Medicaid providers in an ongoing way that clients must receive evidence-based counseling and education about all FDA-approved contraceptives, that cost-sharing, step therapy, failure requirements. I was shocked to learn about this. Like, what do you have to fail? Like, have a baby first, and then we found out that that particular contraception did not work for you. But apparently, step therapy failure has been a component of the way insurance companies have handled this. We're going to stop that in Illinois for Medicaid clients. And prior authorization, we're going to really look at prior authorization processes too. They're not allowed. And we will continue to make timely payments to doctors and FQHCs, not well known in the community. You know, there's a lot of bad press we get about overdue payments and the state the state treasury not being able to pay bills on time. But actually, for doctors and FQHCs, we have been paying on time. We're going to make sure people know that, your bosses, who think that somehow they're not getting payments from us. And we will require the health plans to make timely payments as well. Now, I want to talk to you a little bit about the major transformation Medicaid is going through, because it's very important to understand how this fits into the context of everything else we're doing. Our Medicaid vision is completely aligned with the National Healthcare Reform and the Affordable Care Act. Two components: increasing access to care. We hear a lot about that with people signing up. But that's not the only thing that the National Healthcare Reform is about. It's also about fulfilling what's called the triple aim. So increasing access to care, very important. Illinois embraced the Affordable Care Act completely. Thank goodness we're not one of those states. And we already have 620,000 more Illinois residents who have health coverage today than we did before the Affordable Care Act. That's fantastic. And we were surprised to see that 414,000 already are the newly eligible Medicaid clients. We expected a smaller number, but they came from everywhere, and I think we're going to see even more. Of course, many of these are women without children who are under the income level. The new group that the Affordable Care Act allows now to be eligible for Medicaid are those adults 19 to 64 without dependent children. And many of them, of course, are women. And this is the income, $16,000. Many of your clients, you know, are in this category. So they will be eligible for Medicaid, and they haven't been before. And then the triple aim, very important component, because it's not just about putting a health insurance card in people's pocket. It's about what kind of care are they getting? Are they getting to a doctor? Are they getting themselves healthier with the help of the program? So the triple aim is improving the quality of care, improving the health of populations, in other words, health outcomes, and reducing the growth in healthcare costs. This is a national triple aim. I think it's guiding a lot of the work that's happening all around the country. And in Illinois, there's a state mandate as well, which is that 50% of our clients have to be enrolled in care coordination by January, which is 10 minutes away. You know, when this law passed back in January of 2011, it was really far away, now it's here. And we're doing it right now. And so, but even without the state mandate, we believe that care coordination is important and needed to achieve the AAA. When we talk about care coordination and managed care, we talk about them interchangeably, but there's many varieties in Illinois for how we're doing this. But care coordination does require the redesign of the Medicaid program. And I always want to look at this slide because people say, what's wrong with the Medicaid program? And especially, Kai told me that when she was a health provider, she would say, well, thank God they can always go to Medicaid. So there was a sense that there was a safety net called Medicaid. But truthfully, I believe that we've had 4 problems with the Medicaid program. I distilled the entire it's actually almost close to $18 billion budget down to these 4 problems. First of all, for clients, they have to search for providers willing to accept Medicaid, begging clients to take them, especially if they need a specialist. Good luck. It's very difficult. They're left on their own to do that, and they get little help in navigating a fragmented system. For providers, we don't incentivize them, and they operate in silos. They're not incentivized to coordinate services or to work together to create multidisciplinary teams. The client, therefore, the third problem here is that the client's holistic needs are not considered by any single provider. So our clients have medical needs, we know that, they have behavioral health needs, and they have a slew of social needs. They are the most low-income people in Illinois, and they have some of the most complex issues facing them. And then fourth, the fee-for-service payments that we've had in Illinois Medicaid reward for volume. The more services you provide, the more money you make as a provider. And they don't reward for what we call value, health outcomes, or quality. So our rollout plan is happening right now, and I wanted to make sure that you knew this, and it's very important for everybody to understand this, because in five regions in the state, clients are currently enrolling or will soon enroll in one of the health plans that are being offered. So these are in 5 mandatory regions, they have to be in a health plan. And one of them is in the greater Chicago area. So for those of you, I'm guessing many of you are from up here, Cook County and Collier counties. That's one of the areas where there will be mandatory enrollment. In the rural counties, we're still going to remain fee-for-service, but what this means is that 2 million of our 3 million clients will be in one of the health plans, will be in some form of care coordination sometime by early January or early 2015. We have a unique structure. There's no reason that anybody needs to understand the differences among these, but you will be hearing these words. So we didn't just say Medicaid, we have 3 million people, managed care companies, come one, come all, take our clients. We did something unique. It's a little complicated for that reason, and our clients will feel confused by it, because we have many different health plans of different types. So these are different types of entities that formed just since we went down this path in the last two years. And you can see how many are in each category. So there's 9 different HMOs. Those are the traditional managed care companies. And then we have the other 4 types up here. All of those are organized by providers themselves. So we have a unique structure in Illinois that we're trying something very new and different, and we're excited about the possibilities. But here's the important thing. All of these entities could have members who are the women and girls of childbearing age. All of them. And that means that they all have to understand all of the policies that we laid out today. So what the new world means for family planning providers specifically is what we've been saying. The 5 mandatory regions, providers must be part of these health plans. We're not going to have standalone providers being funded in some other way anymore for Medicaid clients and Medicaid services. The health plans must ensure that providers are offering comprehensive family planning services with your help in helping to monitor that. The providers will be paid by the health plans long term. So what we're moving toward is a system where the state is not paying fee for service, the bills that we get. The health plans are going to get an amount of money for each member, and they will be paying they will be paying for all their providers and all the services. That's not immediate, but when I describe for you the different types, some of them already are doing that, and some are moving toward that in the next 18 months. So on very short order, we are going to have health plans paying the providers. That's why it's so important that the providers be part of the health plans and learn how to communicate with them, negotiate with them, contract with them, and convince them why, and make sure that they're doing all the things that we need them to do through Medicaid. And the health plans and providers exerting right of conscience must offer referrals that are accessible and seamless and convenient. And the state will have to monitor. Our role is changing to managing the managed care plans. That's what we're going to be doing to make sure that they're comprehensive and accessible. Now, I wanted to talk for a minute about the waiver. Many of you know that we've had a waiver for 10 years?
We're in the 11th year.
10 years. And the waiver provided family planning services for women who were not eligible for Medicaid. So these were the women, actually, I don't think I got that right. I wrote that slide. I think it was women from 0 to 200%. Because a lot of women who were in that very low income range still couldn't qualify for Medicaid because they were not in that category that let them become part of Medicaid. So anybody under 200% who otherwise didn't qualify for Medicaid were part of this waiver. So we did seek a year ago, and we received a 1-year waiver extension, and we considered this the transition year. And that waiver expires at the end of this year, December 31st, 2014. The application processing will cease as of September 30th, 2014, so we will not take more applications at that point. And we are discontinuing the waiver because full health coverage is now available, and in fact, it's required under the Affordable Care Act. So for those women who are 138 up to 200%, they need to go to the marketplace and will get comprehensive health coverage for under the ACA. Now what this means is that the women who are under 138%, we call it, which is this income level, 16,000 or 21,000 if they're a couple, they will qualify for Medicaid. The women who previously qualified for Illinois Healthy Women, so the women under 23,000, that's the 200% mark, or 31% for a couple, can now buy private health insurance through the marketplace with tax subsidies. And we're guessing, we asked a question about what that could mean. So a woman who is at the top level, 200%, will pay at the most $125 per month on the premiums for the silver plan coverage, or 6.4% of her income. That's the limit under the marketplace. And whatever that premium costs, she will get subsidies from the federal government to help pay for the premiums. So again, it's very important to help transition our clients, our members of Illinois Healthy Women, to the marketplace by the end of the year. So we need you to join us as partners. First of all, to review the draft Illinois Family Planning Action Plan that's on our website, and to offer your feedback and comments by September 15th. We would like to really finalize this fall. We need you to help develop strategies to educate all of the family planning providers about these new policies. We need you to help develop strategies to educate women and men in Medicaid so they can take advantage of family planning services. You know, 900,000 to 1 million is a big number, and there's a lot of work to do to reach out to them. And we need to educate the women not eligible for Medicaid, but in the waiver to apply for health insurance during the enrollment period, and this is the enrollment period. It begins November 15th. So I thank you for joining us as partners, and we're glad to be partners with you. Thank you.
We have time for 1 or 2 questions for the Director Hamos.
Can you tell me who you are?
I am Stephanie Victor, and I'm with the National Council of Jewish Women. Where does male sterilization fall in terms of contraception? Is that ever provided under any Medicaid or any?
I'm going to talk about that.
Okay, beautiful.
Vasectomy? We're doubling the rate, in fact.
Perfect. Oh, and then second question is
Yes, but we don't have a lot of them. So again, this is an education process.
it's just marketing, yeah.
I don't know how you market men go on and get vasectomies, but I think it's Tia's not supposed to be asking.
Actually, it's a technical correction. Whereas for the private insurance market, the open enrollment period is November 15th through February 15th. Anyone who qualifies can sign up for Medicaid any day of the year.
That's good.
And you can sign up online in the middle of the night even.
That's a good technical correction.
I have a question. There's more incentive for providers now.
I'll just wait for the microphone so we can all.
Can you tell
Thank
me who
you.
are?
My name's Helen Ramirez Odell. I'm with Chicago Teachers Union. And there is more incentive for providers now to provide long-acting reversible contraceptives, which is good. But I'm also concerned, about coercion and pressuring women to have this form of birth control if they don't really want it or understand it. So how can we control that, since this conference is largely about that?
Right. I think it's important to talk to other people than me. We have no intention of having anybody coerced. We do believe in education and counseling as being part of the whole experience of women getting family planning. And education and counseling is very important. But we also think that the various methods should be presented from, this is in fact the requirement, from the most effective to the least, and to give women a choice. And a choice is very important, but they need to understand about all the different options. When I talk to my granddaughters, who are either late teens or young women, they know nothing about birth control. They learn it from each other. So the idea of LARCs is not even known by anybody. So I think, again, this is about education and counseling. It's a very important component, not pressure.
And just to follow up on that point, I mentioned the CDC guidelines, and you're exactly right. One of the central components to quality healthcare is not overuse of contraception. So it's a challenge for us not to underuse, which is what we're describing here, but also not to overuse. And I was really heartened to hear your discussion of training of providers, and I think that's an essential component, because we can have all sorts of thoughts about the public health component, but this is really about individual women and their families and what they want, and keeping that in mind is critically important. I don't know how we'll achieve it, and it's heart-wrenching sometimes to hear how excited we get about the technological solutions. So your point is really well taken, and it's wonderful. We have people here from the Illinois section of ACOG. We have a number of providers, so making that point is really critical.
So we have one last question, but I'll add, all of you should have received a resource sheet when you came in, and the second to last resource is this great article about making the most of the promise of the ACA. And in that article, the author discusses women-friendly decision-making and how to have these conversations and prepare people for whatever method is best for them. So we'll go to our last question.
Hi there, I'm Alicia Ciani from EverThrive Illinois. I think we're all really excited about this action plan, and I just have a question in terms of the implementation of the plan, in terms of what can be done administratively and what requires action from the General Assembly, and then in addition to that, how all of us here in this room might be able to help kind of push that along.
We hope nothing requires action by the General Assembly. We're not big on going to the General Assembly for hardly anything right now. But you can help in pushing it along. I mean, we are working now very hard. As soon as we get your feedback, we are already looking at internally the operational policies that need to change and how we get them done. Some of them, this is a big battleship, the Illinois Medicaid program, with very old systems. So we sometimes can turn on a dime. And it takes a while to get operational policies in place and implemented. But we want to do this soon, and we do need your help with all of these things. We really do. So we'll be working together. This is just the first day of a long conversation. And I also want to, while we see you talking about conversation and communications, so I see Joanne Von Olroth, who is with our agency also as our communications director. So we're going to be doing a lot of communication through this process. Thank you, everybody.